Over 60. 8 brain scan signs of vascular dementia. Doctors miss number 3. Sign number 3 appears on MRI scans 10 years before memory symptoms, but radiologists overlook it routinely. Vascular dementia is the second most common dementia type affecting adults over 60 years old. Only Alzheimer's disease is more common than vascular dementia. Yet vascular dementia is often missed on brain imaging scans because radiologists don't recognize subtle early warning signs appearing years before obvious symptoms develop. 20 to 30% of dementia cases involve vascular components, either pure vascular dementia alone or mixed dementia combining Alzheimer's with vascular changes simultaneously. This means millions of seniors have brain scan abnormalities predicting cognitive decline that goes unrecognized until dementia becomes severe and treatment options become extremely limited. The tragedy is vascular dementia is the most preventable dementia type because it results from treatable cardiovascular risk factors, including high blood pressure, high cholesterol, diabetes, smoking, and atrial fibrillation, all modifiable through medications and lifestyle changes implemented consistently. When brain scan signs are recognized early, aggressive treatment of cardiovascular risk factors can prevent progression to full dementia entirely or at least slow decline dramatically compared to untreated progression. But this requires recognizing scan signs that radiologists frequently miss in routine reporting. Vascular dementia results from reduced blood flow to brain tissue, causing chronic ischemia that damages white matter and gray matter through multiple mechanisms. Large vessel strokes cause obvious damage visible on any scan, but small vessel disease causes subtle changes that radiologists dismiss as normal aging, when actually they predict dementia development reliably. The brain requires 20% of cardiac output despite being only 2% of body weight because of enormous metabolic demands requiring constant oxygen delivery. When blood vessels become narrowed from atherosclerosis or damaged from hypertension, chronic hypoperfusion develops gradually. Brain tissue doesn't die immediately like an acute stroke. Instead, it becomes chronically ischemic, functioning poorly, but remaining alive. This creates the progressive cognitive decline characteristic of vascular dementia. Brain imaging with MRI or CT scans can detect vascular changes years before cognitive symptoms appear to patients or families. But these early signs require careful examination and interpretation by radiologists who understand their significance for predicting future dementia risk. Unfortunately, most radiology reports focus on acute findings like strokes, tumors, or bleeding that require immediate treatment. Chronic small vessel disease gets mentioned briefly or dismissed as age-appropriate changes, when actually these changes predict dementia within years. In this video, we examine 8 specific brain scan signs of vascular dementia that appear on MRI or CT imaging. Each sign is explained with anatomical basis and clinical significance for predicting cognitive decline. Most importantly, you'll learn what to ask your doctor after receiving brain imaging results. These aren't rare, obscure findings. These are common scan abnormalities that millions of seniors have but don't understand their meaning for future brain health. Click subscribe right now, leave a like for the algorithm, share with anyone over 60 who has had brain imaging. Comment if you recognize these signs from your own scans. Now let's examine 8 signs, starting with number 8 and working up to the most overlooked, the one that radiologists miss in 90% of reports despite appearing 10 years before memory symptoms develop. Scan sign number 8, lacunar infarcts showing small vessel disease throughout deep brain structures. Lacunar infarcts are small strokes affecting deep brain structures, including basal ganglia, thalamus, and pons, caused by occlusion of tiny penetrating arteries supplying these regions. Each lacunar measures 3 to 15 millimeters in diameter, appearing as small dark spots on MRI scans. The term lacunar means lake or cavity in Latin, describing the appearance of these small lesions on brain tissue. They appear as fluid-filled cavities where brain tissue died from ischemia and was replaced by cerebrospinal fluid. On MRI scans, lacunes appear as round, or oval hypointense lesions on T1-weighted images, meaning they look dark compared to normal brain tissue. On T2-weighted and FLAIR images, they appear hyperintense or bright with a surrounding rim of gliosis. The location of lacunes matters for clinical symptoms. Lacunes in basal ganglia cause movement disorders, including Parkinsonian symptoms. Lacunes in thalamus cause sensory problems and cognitive impairment affecting memory and attention. Lacunes in pons cause balance problems and gait disturbance. However, many lacunes are clinically silent, meaning they cause no obvious symptoms when they occur. Patients never know they had a small stroke because the location doesn't affect critical functions. These silent lacunes accumulate over years from ongoing small vessel disease. Research shows that lacunar burden, measured as total number of lacunes visible on MRI, strongly predicts future cognitive decline and dementia development. Studies found each additional lacune increases dementia risk by 15 to 20%. The mechanism involves not just tissue damage from individual lacunes, but indicates widespread small vessel disease affecting the entire brain. Lacunes are just visible manifestations of diffuse microvascular damage occurring throughout brain tissue. What radiologists often miss is counting lacunes carefully and reporting total burden to referring physicians. Many reports mention a few lacunes present without quantifying total number or discussing significance for dementia risk. What you must do after brain imaging showing lacunes is ask your doctor specifically how many lacunes are present total. Request quantification, not just description. Multiple lacunes indicate high vascular dementia risk, requiring aggressive cardiovascular risk factor treatment. Ensure blood pressure is controlled below 130/80. Treat high cholesterol with statins. Control diabetes with hemoglobin A1C below 7%. Stop smoking immediately. Treat atrial fibrillation with anticoagulation. All these interventions prevent new lacunes from forming. Scan sign number 7. Cerebral microbleeds, indicating damaged fragile blood vessels throughout brain. Cerebral microbleeds are tiny areas of bleeding in brain tissue from damaged small blood vessels leaking red blood cells into surrounding brain tissue. They measure 2 to 5 millimeters in diameter, too small to cause obvious stroke symptoms. Microbleeds are only visible on specific MRI sequences called susceptibility-weighted imaging or gradient echo sequences that detect iron from hemoglobin breakdown products. Standard MRI sequences miss microbleeds completely, so they require specific imaging protocols. On SWI sequences, microbleeds appear as small, round black dots called blooming artifacts from iron, causing magnetic field distortions. They're scattered throughout brain tissue, in characteristic patterns depending on underlying cause. Hypertensive microbleeds occur in deep brain structures, including basal ganglia and thalamus, from hypertensive arteriopathy damaging small penetrating arteries. Cerebral amyloid angiopathy causes microbleeds in cortical and subcortical regions from amyloid protein depositing in vessel walls, making them fragile. Research shows that microbleed burden predicts future cognitive decline. Studies found each additional microbleed increases dementia risk by 10% after controlling for other factors. The mechanism involves microbleeds indicating widespread small vessel disease, making vessels prone to both bleeding and ischemia. Additionally, iron from hemoglobin breakdown is toxic to surrounding neurons, causing oxidative damage and inflammation that accelerates neurodegeneration. Large numbers of microbleeds increase risk of major brain hemorrhage from anticoagulation therapy prescribed for atrial fibrillation or stroke prevention. This creates a treatment dilemma because anticoagulation prevents ischemic strokes but increases bleeding risk when microbleeds indicate fragile vessel walls. What radiologists often miss is performing susceptibility-weighted imaging sequences that detect microbleeds in the first place. Standard brain MRI protocols don't include SWI sequences, so microbleeds go completely undetected in most routine imaging. Additionally, when microbleeds are detected, radiologists often undercount them, reporting a few microbleeds present when careful counting would reveal dozens or hundreds scattered throughout brain tissue. What you must do is request susceptibility-weighted imaging or gradient echo sequences, specifically when ordering brain MRI to detect microbleeds. If present, ask the radiologist to quantify total number throughout the brain. If numerous microbleeds are present, discuss with your neurologist whether anticoagulation for atrial fibrillation is safe or whether bleeding risk outweighs stroke prevention benefit in your individual case. Control blood pressure strictly below 120/80 to prevent new microbleeds from forming from hypertensive arteriopathy. Scan sign number 6. Enlarged perivascular spaces indicating poor waste clearance from brain. Perivascular spaces, also called Virchow-Robin spaces, are fluid-filled cavities surrounding small blood vessels, penetrating into brain tissue from the surface. They're part of the brain's lymphatic system called the glymphatic system that clears metabolic waste products during sleep. Normal perivascular spaces are microscopic and invisible on standard brain imaging, but when they become enlarged above 2 millimeters, they become visible on MRI scans, appearing as small, linear, or round, bright spots on T2-weighted images. Enlarged perivascular spaces occur in characteristic locations, including basal ganglia, where they appear as linear structures following vessel courses, and in white matter, where they appear as round punctate lesions. The significance of enlarged perivascular spaces is debated among radiologists. Some dismiss them as a normal variant of no clinical significance, but research increasingly shows they indicate impaired glymphatic clearance, predicting cognitive decline and dementia. Studies found that basal ganglia perivascular space burden predicts future dementia risk independently after controlling for other imaging markers. High-grade perivascular space burden increases dementia risk by 50 to 80% compared to minimal burden. The mechanism involves impaired waste clearance, allowing toxic proteins, including beta amyloid and tau, to accumulate in brain tissue, contributing to both Alzheimer's and vascular dementia pathology. Additionally, enlarged perivascular spaces indicate small vessel disease affecting arterial walls, making them stiff and impermeable to fluid exchange. Sleep-disordered breathing, including sleep apnea, impairs glymphatic clearance by disrupting deep sleep when clearance is most active. This may explain why sleep apnea increases dementia risk through impaired waste clearance mechanisms. What radiologists often miss is grading perivascular space burden systematically using validated rating scales quantifying severity. Most reports mention perivascular spaces present without quantifying burden or discussing clinical significance. What you must do is ask the radiologist to grade perivascular space burden if the report mentions them. High-grade burden warrants treatment of cardiovascular risk factors and sleep disorders that impair clearance. Get evaluated for sleep apnea if you snore or have witnessed breathing pauses during sleep. Treating sleep apnea improves glymphatic clearance, potentially slowing dementia progression. Prioritize sleep quality, getting 7 to 8 hours nightly, because waste clearance occurs primarily during deep sleep stages. Scan sign number 5. Strategic infarcts in critical locations causing disproportionate cognitive impairment. Strategic infarcts are strokes affecting small brain regions that have disproportionate impact on cognitive function because they're located in areas critical for memory, attention, or executive function. Unlike lacunar infarcts, which are small and numerous, strategic infarcts may be single lesions but located in critical brain regions, including thalamus, especially dorsomedial nucleus, angular gyrus and parietal lobe, hippocampus and medial temporal lobe, or caudate nucleus in basal ganglia. Thalamic infarcts are particularly devastating because the thalamus is a relay station for all sensory and motor information traveling to cortex. The dorsomedial thalamic nucleus is critical for memory consolidation and executive function, so infarcts there cause severe cognitive impairment from a small lesion. Angular gyrus infarcts cause Gerstmann syndrome with acalculia, inability to calculate, agraphia, inability to write, finger agnosia, can't identify fingers, and left-right confusion. This dramatically impairs daily function despite small lesion size. Hippocampal infarcts cause severe anterograde amnesia, inability to form new memories despite preserved remote memory from years earlier. Even small hippocampal strokes cause devastating memory impairment. Research shows that strategic infarct location matters more than size for predicting cognitive outcomes. Small thalamic infarcts cause worse cognitive impairment than large cortical strokes, sparing critical regions. What radiologists often miss is recognizing strategic infarct locations and communicating their significance to referring physicians who may not understand the anatomical basis for disproportionate symptoms. Reports mention infarct location without explaining why it matters functionally. What you must do after stroke affecting these strategic regions is request neuropsychological testing, measuring specific cognitive domains affected by lesion location to document impairment. Cognitive rehabilitation therapy can help develop compensatory strategies for deficits caused by strategic infarcts that persist despite medical treatment. Aggressive secondary stroke prevention with antiplatelet therapy or anticoagulation, blood pressure control, and statin treatment prevents additional strategic infarcts from occurring and worsening cognitive function. Scan sign number 4. Cortical microinfarcts too small to see on standard MRI scanners. Cortical microinfarcts are tiny strokes affecting the cerebral cortex, the outer layer of brain responsible for higher cognitive functions, including memory, language, attention, and executive control. These microinfarcts measure less than 1 millimeter in diameter, too small to visualize on standard clinical MRI scanners operating at 1.5 or 3 Tesla field strength. Research using high-resolution 7 Tesla MRI scanners shows cortical microinfarcts are extremely common in elderly patients, particularly those with vascular risk factors. Autopsy studies confirm microinfarcts throughout cortex in patients with vascular dementia who had normal MRI scans during life. The significance of cortical microinfarcts is that they accumulate over years, causing progressive cognitive decline from cumulative tissue damage that's invisible on standard imaging. Studies correlating 7 Tesla MRI with cognitive testing show that microinfarct burden predicts cognitive performance better than standard MRI markers, including white matter disease. Each microinfarct contributes to overall cognitive reserve depletion until the dementia threshold is reached and symptoms appear suddenly. The mechanism involves cortical microinfarcts disrupting local neural networks essential for specific cognitive functions controlled by affected cortical regions. Additionally, microinfarcts trigger inflammatory responses that damage surrounding tissue beyond the infarct itself. What radiologists cannot do is detect cortical microinfarcts on standard clinical MRI scanners because resolution is insufficient to visualize lesions under 1 millimeter in size. But certain imaging findings suggest cortical microinfarcts are present even when not directly visible. These include cortical atrophy, disproportionate to white matter disease burden, and cognitive impairment worse than expected from visible lesion burden. What you must do is understand that a normal MRI doesn't exclude vascular dementia because cortical microinfarcts are invisible on standard imaging but still cause cognitive decline through cumulative damage. If you have vascular risk factors and cognitive decline but normal MRI, consider vascular dementia from invisible cortical microinfarcts as a possible diagnosis. Treat cardiovascular risk factors aggressively to prevent new microinfarcts from forming, even though you cannot see them on imaging. Scan sign number 3. White matter hyperintensities predicting dementia 10 years early, most overlooked sign. White matter hyperintensities, or WMH, are areas of increased signal on T2-weighted and FLAIR MRI sequences, appearing as bright white regions in the brain's white matter, connecting different cortical regions. WMH result from chronic ischemia of white matter from small vessel disease affecting tiny arterioles supplying deep brain regions. The ischemia causes demyelination, loss of myelin coating around axons, and gliosis, scarring of tissue. WMH are extremely common in elderly patients, appearing in 90% of adults over age 70 on brain MRI scans. This high prevalence leads radiologists to dismiss them as normal aging findings of no clinical significance. But this is a catastrophic mistake because WMH burden strongly predicts future cognitive decline and dementia development within 5 to 10 years after appearing on scans. Research shows that moderate to severe WMH burden increases dementia risk by 200 to 300% compared to minimal WMH burden. Studies following thousands of elderly participants for decades document this clearly. The mechanism involves WMH disrupting white matter tracts connecting frontal lobes to other brain regions. This disconnection causes executive dysfunction, including problems with attention, planning, and processing speed characteristic of vascular dementia early in its course. WMH also predict progression rate, with higher baseline burden predicting faster cognitive decline over time measured on serial testing. What makes WMH the most overlooked sign is that radiologists mention them in reports but don't quantify burden severity using validated rating scales like the Physicus scale. Reports say nonspecific white matter changes present, consistent with small vessel disease, without grading severity. Additionally, radiologists don't communicate that moderate to severe WMH predict dementia risk, requiring aggressive treatment of cardiovascular risk factors to prevent progression. What you must do is ask the radiologist to grade WMH burden using the Physicus scale, ranging from 0, no WMH, to 3, severe confluent WMH. Physicus 2 or 3 indicates high dementia risk requiring intervention. Ensure blood pressure is controlled below 130/80. Systolic pressure above 140 accelerates WMH progression dramatically on serial scans. Physical exercise improves white matter integrity and may slow WMH progression through improved cerebral blood flow delivering oxygen better. Cognitive training and mentally stimulating activities build cognitive reserve, helping the brain compensate for WMH damage. Repeat MRI in 2 to 3 years to monitor WMH progression. Stable burden suggests good control. Increasing burden indicates need for intensified risk factor treatment. Scan sign number 2. Brain atrophy patterns, distinguishing vascular from Alzheimer's dementia. Brain atrophy means volume loss from neuronal death and tissue shrinkage visible on MRI scans compared to age-matched normal controls. Both Alzheimer's and vascular dementia cause atrophy, but patterns differ, allowing distinction between types. Alzheimer's disease causes characteristic medial temporal lobe atrophy, affecting hippocampus and entorhinal cortex early in the disease course, before other regions. This shows as enlarged temporal horns of lateral ventricles from hippocampal volume loss. Vascular dementia causes a different atrophy pattern with frontal lobe involvement more than temporal lobes initially. This reflects frontal subcortical circuit disconnection from white matter disease and strategic infarcts affecting frontal connections. Additionally, vascular dementia causes subcortical atrophy, affecting basal ganglia and thalamus from lacunar infarcts and chronic ischemia in these regions. Alzheimer's relatively spares subcortical structures until late disease stages. Cortical atrophy distribution also differs. Alzheimer's shows posterior predominance with parietal and posterior temporal atrophy. Vascular dementia shows more anterior frontal cortical involvement initially. However, many elderly patients have mixed pathology with both Alzheimer's and vascular contributions to dementia. These patients show combined atrophy patterns including both temporal and frontal involvement simultaneously. Research using automated volumetric analysis measuring specific brain region volumes can distinguish vascular from Alzheimer's dementia with 70 to 80% accuracy based purely on atrophy patterns. What radiologists often miss is describing atrophy patterns systematically, comparing different brain regions to identify whether temporal, frontal, or subcortical atrophy predominates. What you must do is request volumetric analysis if available, measuring hippocampal volumes, basal ganglia volumes, and cortical thickness throughout brain regions to quantify atrophy. Understanding whether you have predominantly vascular, Alzheimer's, or mixed pathology guides treatment approach and prognosis discussions with your physician. Vascular dementia may respond better to cardiovascular risk factor treatment than Alzheimer's, which requires cholinesterase inhibitors for symptomatic management only. Scan sign number 1. Posterior circulation ischemia from vertebrobasilar insufficiency, affecting brainstem and cerebellum. The posterior circulation supplies brainstem, cerebellum, and occipital lobes through vertebral arteries joining to form the basilar artery, distributing blood to these structures essential for consciousness, balance, vision, and many other functions. Posterior circulation ischemia from atherosclerotic stenosis or occlusion causes characteristic scan findings, including infarcts in cerebellum, brainstem, and occipital cortex that are often missed initially. Cerebellar infarcts appear as wedge-shaped regions of restricted diffusion on diffusion-weighted imaging in characteristic vascular territories. They cause ataxia, dizziness, and imbalance often misattributed to inner ear problems, delaying correct diagnoses. Brainstem infarcts are particularly dangerous because the brainstem contains vital centers controlling breathing, heart rate, and consciousness through the reticular activating system. Even small brainstem infarcts cause devastating symptoms from their strategic location. Occipital lobe infarcts cause visual field defects that patients may not notice initially if bilateral vision is relatively preserved overall. The significance for dementia is that posterior circulation ischemia causes executive dysfunction, memory problems, and visuospatial impairment through thalamic involvement and occipital cortex damage affecting visual processing essential for cognition. Research shows that posterior circulation strokes have higher cognitive impairment rates than anterior circulation strokes of equivalent size because of thalamic involvement affecting all cognitive domains through disconnection mechanisms. What radiologists often miss is recognizing the posterior circulation ischemia pattern when infarcts are small and scattered throughout posterior fossa structures. Reports mention individual infarcts without recognizing the overall posterior circulation distribution. What you must do is ensure vertebral artery imaging with Mr. Angiography or CT angiography, evaluating for stenosis or occlusion requiring treatment with antiplatelet therapy. Posterior circulation TIAs with transient dizziness, visual changes, or ataxia require urgent evaluation to prevent major stroke from occurring within days. These 8 brain scan signs predict vascular dementia years before symptoms appear: lacunar infarcts from small vessel disease, microbleeds indicating fragile vessels, enlarged perivascular spaces impairing clearance, strategic infarcts in critical locations, invisible cortical microinfarcts accumulating progressively, white matter hyperintensities, most overlooked, atrophy patterns distinguishing vascular dementia, and posterior circulation ischemia affecting brainstem. Request detailed reporting of these signs when receiving brain imaging. Ask the radiologist to quantify lesion burden using validated rating scales. Treat cardiovascular risk factors aggressively to prevent progression of vascular damage. Which scan sign did you recognize from your own imaging? Comment below sharing your experience. Share with anyone having brain scans performed recently. Subscribe for more dementia prevention content posted weekly. Thank you for watching this video about brain scan signs of vascular dementia that doctors miss routinely in reports. Advocate for detailed reporting yourself.